Hello, and welcome to today's Medley Moments conversation. As I've suggested in the past, Medley Moments is an opportunity for me to bring forth leaders who are mission-driven, who understand the importance of collaboration, new ideas, innovation, designed towards impact. Today, I am thrilled to have two people who really do exemplify all of those traits. I've had the opportunity to be involved with the Mount Sinai Health System in New York. It is the largest academic healthcare system in New York City and one of the largest in the country. Dr. Carol Horowitz and Dr. Lynne Richardson are co-founders of the Mount Sinai Institute for Health Equity Research. This work really matters. Healthcare is a differentiator based upon who you are, where you're born, and your access to care. And Carol and Lynne and their colleagues are doing extraordinary work to create broader access and health equity. So let's just get started, Carol. Tell us a little bit about your medical background, and then define for us what we're talking about when we talk about health equity.
I'd like to begin with gratitude. We are very passionate about our work. We've committed our lives in the service of health equity. These are challenging times, and this is a real wind in our sail. And we thank all of you for your attention, and especially Edith, thank you for allowing us to have this moment. So I am a primary care doctor. I'm a general internist. And it's been my pleasure my whole career to take care of patients. And early on in my career, I started noticing, I kept seeing the same things again and again and again. Somebody with uncontrolled diabetes and hypertension and a lot of different things. And I kept saying, why do I keep seeing the same things again and again and again? So I decided to kind of move the lens back and look at a bigger picture and say, what is going on with health? Why do we keep seeing these things? So, one of the things that we know is that your zip code, your subway stop, the driveway you pull into should not be related to how long you live, but it is. So right now, when I see my patients, I'm in a building that's the intersection of two neighborhoods, Upper East Side and East Harlem. Upper East Side, predominantly white, wealthy, lowest likelihood of dying due to preventable illnesses in the city. East Harlem, just north, predominantly non-white, low income, and has the highest rate of deaths due to preventable illnesses in the city. Now, you could just walk across 96th Street, right? There's no wall. You can easily go from one neighborhood to the other. Yet, people in East Harlem have 10 times the likelihood of getting their foot amputated due to diabetes than their neighbors right to the south on the Upper East Side. And on average, they live 10 years or less, 10 years less long. This is what we call inequities. These are differences in how well people live and how long people live that are unfair, that are unjust, and that are avoidable. Those are what inequities are. And there's similar inequities across our country, our world. So Lynne and I are both honored to take care of patients. We're also really inspired that we have this privilege to understand and address the root causes of these inequities, because no one wants to be sick. No one wants to die young. These problems aren't due to bad behaviors, these inequities that we're talking about. Systems are designed to get the results we see in our world. So Lynne and I, our whole institute, are committed to building these systems and policies to eliminate inequities and achieve health equity.
Thank you, Carol. Lynne, would you take us through the creation of Institute for Health Equity Research, known as IHER by all of us who are on the task force and who have been engaged since the beginning? Why did Mount Sinai and this Icahn School of Medicine create IHER? And where are you now on this journey?
Yeah, thank you so much, Edith. And again, thank you for this opportunity to talk about our work. The Institute for Health Equity Research was created by Mount Sinai in May of 2020, and you will all recall we were in the midst, actually at the beginning of the COVID pandemic, and I think there was a desire on the part of the institution to elevate the kind of research that Carol and I do, and that we had been doing for many years, to a higher level and to focus on health equity research in the same way that the institution focuses on neuroscience or stem cell research or other important areas of science. And what the Institute allowed us to do was to bring together scholars and investigators from across Mount Sinai initially, and later from outside of Mount Sinai by recruiting faculty, to bring them together in a single institute to collaborate on these complex problems that result in the health disparities and the inequities that Carol was describing. Like Carol, I'm a physician who sees patients. I'm an emergency physician, and the view from the emergency department is perhaps the ideal place from which to see the failures of our current healthcare system. People who fall between the cracks, people who experience disease and complications because they don't have access to care. I see them every day in my clinical practice. And so I also was motivated to take a larger lens. I became a physician to help people. I was born in Harlem, and I became a physician to help people who live in communities like Harlem. And then I went into research to understand why people who live in communities like Harlem have such different health outcomes and such different lived experiences than people who live in other communities. And that's what we do at iHeart. We use data to understand why inequities occur, and we use the tools of research to devise interventions to change these inequities. And as I like to say, our research is really aimed at changing what is into what should be, which is everyone should have the same opportunity to achieve their highest level of health. And data can help make that possible. Research is not about, something that's discovered in a dark room in a laboratory with a microscope. It's really using data to change real world situations so that people's health is better. And that's what we do at iHeart.
So I just want to repeat that because I think that is really an important point. Research is designed to move what is to what should be. And you've both highlighted some of the examples of health equities that exist right in the ecosystem of where Mount Sinai operates. Can you spend a minute talking about the whys? Because I would say most physicians become physicians and give an oath to care for their patients. So why has this inequity developed over time? And give me some examples of things that you're thinking about and working on that could make what is not what will be. Carol.
It's a really important question, and there are several reasons. One thing is I think we have to look at just systemic inequities in our world. So why is our world different for different populations? For many different. We have unequal educational systems, systems of wealth, systems of justice, and all these have led to some communities having more opportunities than other opportunities. And the injustices we see in other types of systems are no different than when it comes to the health space. So first of all, we have to realize that a lot of health doesn't have anything to do with health care. It's what's going on in people's communities, where they live, where they work, where they play. So a lot of this puts some people to systemic disadvantage. Once they get to our system, people have less advantage of having access to care. They might come in with more stress and more illness in the beginning. Then when they get to our system, there's also disadvantages baked in to some of what we do, which we're just starting to untangle recently. So I'd like to give you just a couple of brief examples. One of them is when we measure people's kidney functions, right? We use equations. A lot of medicine has equations in it. And historically, the equation we used to measure people's kidney function made it look like Black people's kidney function was better than it really was. They used a different equation, a correction for Black people. What does that mean? When your kidney function gets bad enough, you can be on a list to get dialysis. And then you're on a list to get a kidney transplant. Really, a kidney transplant is the cure for kidney failure. Yet Black people were systematically disadvantaged because it looked like their kidney function was better than they were. And they weren't getting on the transplant list when they had the same level of kidney function as white people. It took a while before people realized this and did the research and said, wait a minute, we're using the wrong equations. We're disadvantaging people based on math. So what people did, and people in IHER did, some of the people that Lynne and I had the pleasure of recruiting because of the support we get to recruit talent, is people undid the equation, took away the disadvantage, and then went to the organ transplant organization and said, these folks have been on the wait list 10 years less time because we overestimate their kidney function. And now the United States organ transplant system is giving people back time in their wait list. There are people who got 10 years ahead on the wait list of where they were because they were disadvantaged. So that's an example of finding a problem, solving the problem, and rectifying the problem.
Thank you, Carol. Lynne, you were going to add something?
Yeah, I love that example because it is a perfect example of research first to identify that this formula that we were using, this algorithm, was unfair and was not based on evidence. And then the advocacy to actually change that so that now any system in any hospital in the US that does transplants must use the race-neutral formula for calculating kidney function. And then at the very end, denied patients because we were using this flawed algorithm. And so that it's a great example of what we mean by structural inequity. This was built into the systems we use. This wasn't, some doctor or some institution doing something bad. It was literally in the laboratory systems we use, this calculation. So doctors didn't even know this was being done, that this formula was being used. And I think that's why it's so important for us to take our health equity lens wherever we see unequal outcomes and start asking that question, why? Why is it that some people have worse outcomes from chronic kidney disease? Why is it that some groups have worse outcomes, for example, from high blood pressure? To give you an example that I see in my own practice in the emergency department, where we see people all the time. Hypertension is the leading killer of people from all groups. But we see increased rates of death and complications of stroke and heart attacks and kidney disease in some subpopulations. Why? Why is this disease affecting different populations differently? And as we look more closely, we understand all of the reasons why that is, because they don't get access to care. They don't have their blood pressure checked. They don't have access to healthy foods. They have higher levels of stress. And so then it becomes, so what do we do about that? And we have, for example, another investigator who's in our institute who is focused on this problem of people with high blood pressure who are in the emergency department. And she demonstrated that people who were there who had a diagnosis of hypertension and had their blood pressure found to be out of control during this visit, regardless of why they were in the emergency department, 100% of them have structural heart disease. So their high blood pressure has already started to damage their heart when we look at an echocardiogram for these patients. So now we're going to the place where these people are, and we've devised a number of emergency department-based interventions for patients who are there, whose blood pressure is out of control. They are largely disadvantaged, overwhelmingly Black and Latina. And we have devised a number of interventions to help link them to care to get their blood pressure under control. We have a nurse-led intervention that explains the way their blood pressure is damaging their heart, because people don't understand, right? blood pressure is just a number. And until it does damage, you don't feel it. And so people aren't motivated to take care of it. We have another young faculty mentor who's devising a community health worker intervention, again, in the emergency department to help people with high blood pressure address all of the types of social adversity that may be getting in the way of them getting care. So someone to help them navigate our healthcare system with getting to a primary care physician like Carol, dealing with things like transportation issues or food insecurity or other things that may interfere with their ability to take care of their own health. And so that's how we change the needle, by finding the problem and then devising ways to get to equitable outcomes for everyone.
Well, I think that that is an excellent example, Lynn. And, you know, everyone, I'm aware that the video for Lynn is a little start and stop, but it doesn't matter because we can hear her. We're learning from her. And so we're just going to keep moving forward. High blood pressure, that is, as Lynn described, I think you said it was the largest killer.
It's a leading cause of death if you look at all of the complications. Yeah.
It's a leading cause of death. Now, I'm going to share something really quite personal here, because I think it really is an example of an outcome when someone like myself has access to health care. Several years ago, I wasn't feeling great. I went to the doctor. The doctor said, "Oh, your blood pressure's a little bit high. It's probably white coat syndrome. You live a really stressful existence, don't you? I would just take it easy. You know, I'm sure it's fine. We'll check it again, you know, in your next appointment 6 months from now." And I talked to a dear friend, Dr. Paula Johnson, who's now the president of Wellesley, but a renowned cardiologist focused on women's health. And she said, let's go into this. Turns out I have high blood pressure. I have the beginning of heart disease. I have, and the list goes on. I thought I was pretty healthy. I exercised all the time. I went to the doctor. And it's completely manageable. It's completely manageable. And I found myself thinking at that time, what if I didn't have access to a primary care physician who got me on the schedule? What if I didn't do a little bit more due diligence? What if I didn't have a trusting relationship historically with healthcare providers, i.e. the only time I was in it with a healthcare provider was when things were really bad. I might not have had the same outcome. And so I would just ask, before we go back to Carol, everyone who's listening to this, to think about that. Think about the fact that if you do have access to healthcare, what that means to you, and what happens if you don't, and the implications that has for those individuals who don't have access, but also for our society at large, because it has implications for our society at large. So Carol, let's talk about that for a second. Let's talk about how you take an incredible health system like Mount Sinai, experts across all different types of research, practical care. How do you bring it all together? Because didn't just hire people, you collaborated with people. How did you make that happen?
So I want to just stop and for 1 second and hear what you said, because it's so important. There are, you pointed out two things. One is not enough of us go to the doctor. And sometimes when we go to the doctor, we hear something and we need to hear more and we need to advocate. Now, you had the privilege of having somebody else that you could run this by. But I think these are two important things to highlight before we get to our system. I know for me, getting personal as well, when I went through menopause, I gained a lot of weight. and I was embarrassed. And I didn't want to go to the doctor and have the doctor say, oh, drink more water, exercise more, and eat less fatty food. So I didn't go for a few years because I didn't want to get fat shamed. And then when I finally went, I had an illness that I didn't know I had that I should have attended to sooner. So I do think it's really important to get over whatever the inertias we have, whether it's something like I had that I was embarrassed, and go to the doctor if we can get to the doctor, and also to be in a position where we ask really, really good questions. If something doesn't feel right, if the blood pressure is a little high and somebody says, wait, Google it, ask a friend, get a second opinion, or say to the doctor, why do you think it's not important? So I want to thank you for sharing that and say this is really important. We use the term not mistrust, but earned skepticism, because our systems haven't always been trustworthy enough and respectful enough of our patients.
Earned skepticism. That's an important clarification. Thank you,
Carol. It really is. It really is. We're not blaming the patient here. We're saying I need to do a better job. After I did this, I went to my patients who were chubby and said, I'm really sorry. I was hardcore. I'm here. I don't have to weigh you. Let's move forward. So I think we have to think about the systems and making the systems healthier. In terms of what we're doing at Mount Sinai, we have a combination of looking at our culture and looking at our systems. So we do a lot of work of leaning in and helping people understand how to give better, more compassionate care and be trustworthy for their patients. In addition, we put in what we call equity dashboards across our system. So using big data, we can go to every department, every single shop, whether it's internal medicine where I am, the emergency department, surgery, wherever it is, and saying, let's look at the profile of your patients. Who's getting the right care? We know what's right. Who's getting what's right and who's not getting what's right? And let's figure out who's not getting what's right and do something about it. Whose blood pressure is controlled? Who has a blood pressure that's elevated, but they're not on medication? And are they more likely to be a certain age, a certain racial and ethnic group, have a certain kind of insurance, be a certain sex or gender? So we're doing a combination of approaches to build understanding and really build systems using data to target and address inequities.
One of the comments that we have here is from someone who wants to hear a little bit more about how nurses play a role in the work you're doing at iHeart. Would you comment on that, Lynne?
Well, I love working with nurse scientists, and I've had the privilege of mentoring a couple of nurse scientists who now are part of iHeart and doing really impactful work. Nurses are trained differently. They have different kinds of connections to patients. And we really need to make sure that every member of our healthcare team, whether it's the physician, the nurse, the technician, and so on, are all looking at this as a team effort to really optimize the outcomes that we give our patients. We as providers have to hold ourselves accountable for equitable outcomes, which means you can't just do the same thing for everybody because everybody doesn't need the same thing. If I have 10 pints of blood and I give 1 pint to each person and 9 of them didn't need blood and 1 needed 10 pints, that's not good care. Even though I could say I did the same thing for everybody. That's not what medicine is about. It's about helping everybody attain the highest level of care because we need healthy citizens. Employers need healthy workforces. We need everybody to be able to contribute to our society. And when you're not healthy, you lose all of that. And so I think there's been a growing understanding of all of the things that we can do within the healthcare system and as providers to improve health outcomes for our patients. And I really think it's our obligation. It's our moral obligation and professional obligation to do that, to do those things.
Carol, you're nodding. Did you want to add something?
I wanted to add that one of the things that we need to do as we innovate in healthcare is we need to recognize that this innovation and the impact take a village. So, someone like you, Edith, you've chosen to innovate in your own space. You're a leader in your field. You've also joined our village to support our work and guide us to maximize our impact. So when we think about how to improve healthcare, we do the best we can within iHeart, but our philosophy is to bring in partners from the communities most unjustly impacted by inequities, policymakers, health system leaders and industry, because it's going to take all of us to look at this healthcare system and say, how do we do this better? And we're finding a lot of our innovation, our impact come from building these kind of partnerships. You know, a community mentor of mine taught me, you know, you can't wring your hands and roll up your sleeves at the same time, right?
You all are sharing some real jewels here. You can't wring your hands and roll up your sleeves at the same time. That is really appropriate.
Yes. For this moment, you have to make a choice as to which one you're going to do.
So we really want to hear from people on this LinkedIn now or later. You know, how do you think we should roll up our sleeves? You want to roll up your sleeves with us? Join us. How do we face these challenges? How do we fuel our fires? Because we know what we're doing. We're doing a lot, but we need new ideas. We need new partners. We need new resources to keep this going.
Yes, and we need support for to keep the research enterprise going. That is the path to improved health for all of us. And so we're so grateful to people like Edith and others who have supported us in this work so that we can have data-driven solutions, that we can be guided by facts and science and not lose any more people, not have people suffer avoidable illness and disability because they're not able to access all of the resources they need to attain and maintain health.
So you've mentioned data a number of times and how important it is to have a data-informed perspective on the research that you're doing. With the increased capacity or capabilities associated with technology and AI and large language model, do you find that you're able to manage larger pools of data, and do you have the information that you need such that the outcomes of your analysis are truly a reflection of as broad a swath of individuals? Going back to what you said earlier, Lynn, you know, you don't treat two patients exactly the same because there are no two people that are exactly the same. How do you juggle those competing tensions or opportunities? Let's call them opportunities.
They are opportunities, Edith, you're right. AI is a powerful tool. And there's no question that it now allows us to do analyses almost instantaneously that previously might have taken hours or even days to run. But like any tool, it can be used well and appropriately, and it can also be misused. And so it's really important as we become more dependent on artificial intelligence and machine language tools that we make sure we're not embedding the biases that exist elsewhere in our healthcare system into these tools. And that can happen if we're not paying attention. AI algorithms are trained on data sets. And if there's bias within those data sets, that's what the AI tool learns is how things are supposed to look. So we have to really be vigilant and learn how to use these tools. We have a number of projects within our institute that make use of this powerful technology. And I think it's important to not be afraid of it, but it's also important to make sure that it's used wisely and governed appropriately.
And very briefly, when we're looking at big health systems like insurance systems or healthcare systems, we have a lot of data, but we also do research. And for research, people need to be part of research. And we know people are sometimes skeptical of getting involved in research, but we only know what we can measure. So for example, the pulse oximeters, the thing we put on people's fingers to measure oxygen, those are developed in people who had light skin, in white people. What we didn't realize is the little LED sensors didn't measure if you had more melanin, you had darker skin pigment, they were not as accurate and made you look like you had better oxygen than you really did. They systematically disadvantaged people. So now Lynn and I are part of a project to develop new ones that are bias-free. But that's an example of when you're saying, do we have all the data? Sometimes we do, but for research studies, if we don't encourage diverse people, and if diverse people don't step up, we will keep making mistakes like that. And we have to avoid those in the future.
Well, I think that unfortunately we are at time, but I think this is probably a good place to pause and ask you, Carol and Lynn, just for some closing comments. Here's mine. Thank you. Thank you to you both for being the founding directors of Mount Sinai's Institute for Health Equity Research. It has been a privilege for me, and I think I could speak to others who have been engaged, to be helpful in any way to the work that you're doing, because it really matters. I would say that the exciting thing about getting together and getting updates is that I always leave with a list of questions and things that you put forth as new opportunities to explore, because there will always be new opportunities for impact. And so first, you, Carol, what message would you like to leave here? And then Lynne, if I could ask you how to share how people can reach out and get engaged with the work that you're doing.
We're doing this work in a very complicated time right now. And I want people to leave with a sense of optimism that we're going to keep doing this work. We're not giving up. And for people to share their best ideas with us, because we need to fill up our banks right now so we can move forward. And I mean our emotional banks, our inspirational banks, so that we can do our best work. And we hope you'll join us.
Lynne.
Yeah, and I would call upon anyone who's interested in the work we're doing. You certainly can go to the website to learn more. We do a lot of work with community partners, so there are lots of ways to get involved with our institute, even if you're not a scientist or a healthcare professional. And of course, it always takes financial support to keep doing the work. Everybody has to sort of make a decision about what is going to be their way to contribute, because as Carol said, it really takes a village to keep moving all of us forward. We want to harness science and transform the healthcare system so everyone can attain their highest level of health. That's what health equity is.
Well, Lynne, Dr. Lynne Richardson and Dr. Carol Horowitz, thank you so much for joining me in this Medley Moments. Medley is really about creating centers of gravity so people can share and learn and grow for impact themselves, but really for the impact of the medleys that they operate in their lives. I, again, have so benefited from being part of the extended iHer community and look forward to continue to work with you. And to all that are interested, please follow up, but also look in your communities. I know that Carol and Lynne spend a lot of time, on outreach in other parts of the country and the world, sharing best practices, et cetera. So whatever makes sense for you. But what really is important is that we all pay attention to other people's experiences, particularly with respect to healthcare. All right. Thank you very much.
Thank you so much for having us. We're honored.